We'll be talking about hypermobility spectrum disorder, which is I think, sort of an interesting collection of particular pain disorders. So we'll talk. Oh, sorry, is it not close enough? Okay, yeah, thank you. So just a little bit about me. I'm a physical medicine and rehabilitation physician, a physiatrist. I trained at the University of Pittsburgh Medical Center, and what I do is non-operative orthopedics, and so this includes a lot from physical therapy management, script writing, ultrasound for diagnostics and injections, as well as some fluoroscopy procedures. So I do a lot of this musculoskeletal diagnosis and management, and this is a disorder that has been increasing in recognition and sort of popularity. This is discussed a lot among patients, particularly in the US. So I got really interested in looking at this. I should briefly say I have no disclosures to make regarding this presentation, except that this is a really low level of evidence space. This is something that we don't understand particularly well, which I think is a good reason to talk about it. So it is a very underdiagnosed syndrome. I think it's much more prevalent than most of us realize. It is the intersection of pain and musculoskeletal world, really definitionally. You'll see this in pediatrics, you'll see this in adult patients. Increasingly, it is talked about in online forums. There are lots of support groups for these particular diagnoses. And so these are patients who are talking to one another and who often come in seeking care because they have heard about this diagnosis, reading online or otherwise. So they often present to you already thinking that they have these. So it's important for us to understand what it is, so that if they do come in and ask, you can actually have something meaningful to say. There's a lot of medicalization around these diagnoses. So people are wanting care, they're seeking care, they're looking for specific medical care about it, and we have to know something. So if we don't talk about it, we won't be able to do it. So today we'll be talking about these hypermobility syndromes, what I mean when I say hypermobility syndrome. We'll be talking about the epidemiology, how to make the diagnosis. We'll talk about some general complaints, what people might present to you talking about. And then we'll move to a system by system, joint by joint discussion of some of the pain complaints that these patients will have and how to specifically treat those areas. And then I'll leave with some general principles for treatment and some take-home points so that there's a nice framework for you to understand these disorders and then how to manage them. Okay? So when we're talking specifically about hypermobility syndromes, we can mean a few different things. You may remember, or you may have learned about classical Ehlers-Danlos syndrome. This is the poor wound healing collagen defect that is autosomal dominant, that comes with joint and skin hypermobility. Often we talk about this papyraceous skin, this papyrus skin, very fragile scarring. Okay? This is separate from that. This is a hypermobile type Ehlers-Danlos or a hypermobility spectrum disorder. They often have velvety skin, but not necessarily poor scar healing. Okay? We think that it is autosomal dominant, but we don't have a clear genetic link to this. There is not a genetic test for this that you can order. Okay? It is female predominant, and this is by far the most common of the hypermobility syndromes. Okay? There are other kinds of Ehlers-Danlos. So there are the vascular type, which we think about a lot because it's quite deadly. This is not what we're talking about today. We're not going to discuss that. Kyphoscoliotic is in the neighborhood, but it is not quite what we're talking about. We're talking about that hypermobility spectrum disorder. So in the broader scheme of things, there are things like Marfan's and cutis laxa, tenascin X deficiency, all things that are hypermobility syndromes, all things that are much more severe than hypermobility spectrum. Okay? So we're talking about this in the middle, that sort of overlay of hypermobility syndromes and Ehlers-Danlos. I think of this as a spectrum because many people have hypermobility, right? Very flexible joints, but do not have pain. We think about gymnasts. Many athletes have a lot of very flexible joints, but don't have pain problems. So we think of those patients on the left, familial articular hypermobility, generalized joint hypermobility. These are patients with hypermobility but do not have pain. And then there's hypermobile type EDS, or Ehlers-Danlos syndrome, who do have pain. So this is a spectrum really between them. Some people have some hypermobility, some pain, some none, some a lot of pain, right? So this is a very, very varied expression. We call this pleiotrophy. We think that it is the intersection of hypermobility with some kind of environmental factors, things like mechanical forces, lifestyle, jobs, car accidents. It's the secondary effects that are mediated by joint hypermobility. Okay. So we'll talk about epidemiology. This is very common. Roughly 10 to 20% of the patient population, or just broadly the population, is going to have hypermobility. Not hypermobility with pain, but hypermobility. It is more common in children and adolescents, females, Asian, West African descent, much more common to have hypermobility. There's only one study that I can find talking about hypermobility with pain, this hypermobility spectrum. About 3% of at least a UK population will have this. So it's very common. We do see a reducing prevalence of hypermobility as patients age, which we believe is due to scarring and some age-related reduction in the mobility, the elasticity of joints. Okay. So then how do we make the diagnosis of a hypermobility spectrum disorder, or this hypermobility with pain? There are a lot of different scales. I use what's called the Beighton score. Okay, it's relatively simple to take. The scoring is up to 9. Okay, and you guys can do this here today with me. The first thing you do is you try to take your thumb and you bend it back to touch your wrist. If it bends back and touches, other way in deflection. Yeah, there you go. If it bends back and touches, that's 1 point per side. Okay? If you can put your hand flat on the table, and if you can pull your fifth finger, your pinky, beyond 90 degrees, that's another point per each side. Okay? If you have more than 15 degrees of extension in your elbows beyond, neutral, 0, so if you get that hyperextension there, that's 1 point per side. If you get more than 5 or 10 degrees of extension in your knees when you're standing, beyond 180, that's another point per side. And if you can put your palms on the floor with your knees extended, bending over forward, that's another point, okay? Which is 9 points in total. It's positive if you have greater than 6 if you're before puberty, 5 from puberty to age 50, and 4 beyond 50. Some of this can be historical. So if you have somebody who had a wrist fracture, can do it on one side but not the side they you got a fracture, that's still positive, okay? For me, from a pragmatic, simple approach, if you have pain in multiple joints and you have a positive Beighton score, you have hypermobility spectrum. You have a pain disorder associated with hypermobility. There are more formal diagnostic criteria. There's this Brighton criteria here, which you see has some of these, right? 1 to 3 joints, dislocations and subluxations, pain, right? Soft tissue rheumatism. But simply, if you have hypermobility and pain, you have this, right? There are ways to make formal diagnoses. The hypermobile Ehlers-Danlos, international consortium came up with this. This requires family history, all kinds of other things. I don't think this is necessary. I don't think this is necessary to treat patients or diagnose them, but it's there if you're interested, okay? So what do people complain about? What is the general complaint? What will people show up to your office and describe to you? Number one, thing is joint instability. They will describe subluxation and dislocation. It is not that frequent that you see true dislocation, but often subluxation, right? That clunking sensation of joints, particularly in the shoulder, but often the digits. I see it a lot in the thumbs. The patella, often they'll have some sublux of patella. Joint pain will be present in 100% of people. That's part of the diagnostic criteria. You'll see IT band syndrome. Paradoxically, the IT band is very tight. Okay. TMJ, right, temporomandibular joint, and there is some tendinopathy. There's conflicting data on early osteoarthritis. People will often talk about it. I don't really see that. It's not very common. Reduced bone density, likewise, some conflicting data, but we'll talk about what this means in the spine in a bit. There's a lot of sleep disturbance, fatigue, headaches, myofascial pain. I think kind of critically, there is poor proprioception. Proprioception is a sense that is derived from stretch, right? When we have stretch in our tissues, our bodies can sense that stretch. That is what gives us proprioception. If you have impaired stretch, if you are too flexible, you do not know where your body is in space. When you talk to these patients, you can ask them if they were a clumsy child, if they tripped, if they fell. They often do. It's because they have poor proprioception. It doesn't have anything to do with being clumsy. They really just can't feel where they are. Okay. There are a lot of psychiatric issues that are often comorbid. There's also a lot of neuropathic pain, and it can mimic specific neuropathic pain. So they might describe to you a carpal tunnel syndrome or a cubital tunnel syndrome, or a very specific radicular pattern in the neck or the back. You will almost never find this on an electrodiagnostic study, an EMG nerve conduction study. We think it's due to stretch of nerve causing irritation, but not true injury. Okay. But really characteristically, you will have chronic pain. And this pain will be much more severe in their description than it is on imaging. If you obtain x-rays or MRIs, you are very unlikely to find anything at all. But they will describe to you debilitating pain. And this is really, I think, a hallmark. We believe that this is due to repetitive microtrauma, so very small injuries, very small irritation and inflammation that accumulates over time. These joints are moving more and have more variability in their movement than they should. This creates a combination of central sensitization with poor proprioception that leads to weakness and kinesiophobia, or fear of movement. If you're afraid of moving, you get weak, right? And if you get weak, then you get worse at moving, and these patients quickly spiral. Right? And I think that to a large degree, psychiatric conditions play a role in that. People get depressed, people get anxious, and that really doesn't help at all with their pain. There is a strong component of autonomic dysfunction. So POTS, that postural orthostatic symptoms that you get in atypical chest pain, very, very common. I won't go through all of these, but there's a lot of dizziness, lightheaded, pre-syncope type symptoms. And we believe that this is due to one measurably different response to alpha and beta adrenergic agonists. But we think that it is largely due to the fact that these are stretch receptors that are present in our vasculature. When those stretch receptors don't function appropriately because, again, these patients don't stretch appropriately, they don't respond well to pressure changes, postural changes. Whereas normally you might detect that change in pressure in your vasculature, these patients cannot. And so they have a lot of autonomic dysfunction. There's no association with prolapses. There is a sort of small amount of aortic root dilation, but doesn't have any kind of complications. And so cardiovascularly, this isn't really all that impactful apart from the orthostatic symptoms. There's a lot of functional bowel disorders, right? Similarly due to the stretch. Delayed gastric emptying, and there's often refractory to treatment. They will have short labor and delivery for obvious reasons. Those tissues are very, very lax. Those ligaments are very, very lax. There's often premature rupture of membranes and postpartum hemorrhages. And they will have persistent pelvic pain afterwards. Right? Those tissues never return entirely to normal. They'll also have an increase in the dysautonomia. This is really impactful for the patient's lives. Functionally, these patients report a much lower score than most of the general population, right? And so their health-related quality of life is quite low. So this is a lot of stuff, right? This feels like a lot. We're going to do a lot more on a joint-by-joint basis. Does anybody have any questions before we go on? Okay, cool. This should sound familiar because there is a lot of overlap with fibromyalgia. Right? When we describe this, it sounds a lot, and I think that this probably often gets misdiagnosed as fibromyalgia because of that overlap, because of the lack of imaging findings. And so I think a lot of the stuff that we call fibromyalgia is this. Right? And if you really start thinking about it, and you keep this in the back of your head when somebody has those symptoms you can't explain, and then you go and test them to see if they're hypermobile, and they are, that should start to make more sense. I like this because fibromyalgia patients are quite challenging to treat. This is easier. This has a solution that fibromyalgia doesn't, and so it's really important to recognize it. You've probably seen a lot of these patients and you just didn't know. It is important to note, too, that symptoms often change over time. Some patients are quite fine and can use their hypermobility, and at some point really deteriorate. I have patients who are quite active. They were athletes, they were gymnasts who used that hypermobility, and as they aged and as they stopped using it as part of their sport or otherwise, they really, really deteriorate. And so they might have some symptoms that kind of change over time. So we're going to go through a joint-by-joint basis, and we'll talk about how hypermobility impacts pain within individual joints, really from head to toe. We'll talk about the spine, the individual shoulders, hips, and knees. But before we really get into it, I do want to talk about an important distinction, which is that there's a distinction between macro and micro trauma. Macro trauma is the big trauma, right? Dislocations, subluxations, soft tissue injuries, sprained ankles, ACL injuries. These are injuries just like anybody else can get, and they require the same kind of treatment that anybody else who gets those injuries gets. That can lead to acute pain, loss of function, and we ought to treat it as such. There is also microtrauma, which is probably the more challenging. This is that subtle, quiet injury. There's that increase in movement of joints that causes irritation and chronic pain and leads to a chronic sensitization to that pain. It's persistent, recurrent, and doesn't really show you any imaging findings, and so it's really hard to recognize it. So when we look at the shoulder, one of the hallmarks here is multidirectional instability. So somebody who's had a dislocation and has a primary direction of instability, that's not the same, right? We're talking about people who sublux inferiorly, posteriorly, anteriorly, who has a lot of instability in that shoulder. That reduced proprioception that we talked about really impairs people's shoulders. Shoulders are very complicated joints, right? You have a huge range of motion, you have scapular motion that's also included, and all of that together requires a lot of coordination that these patients don't have. When we look at their muscles, they have early activation and late termination, and so you have a reduced peak amplitude and intensity of that muscle activation, so they don't have good control. This results in altered neuromuscular control of the glenohumeral joint and the scapula, and I find that the scapula is often where people are most symptomatic with pain. The muscles around the scapula are overworked and very, very painful. And there's actually a chronic downward rotation, and we'll talk about what that looks like, of the scapula. But what that does is it opens up the bottom of the glenoid, and that allows frequent subluxation inferiorly as you no longer have the bottom of the glenoid to support the shoulder joint itself. And so you get this sort of constant sublux. They'll be walking, they'll be moving, they'll be doing things, and their shoulder is just constantly moving out. So this is what downward rotation looks like. It's more that movement medially, especially of the inferior border there, so about like this. And you can see how that really moves that glenoid out of the way on the inferior floor. and allows the joint to just constantly fall out of space. Okay. There can still be a primary direction of instability, particularly if a patient has had a true dislocation. And you can see a sulcus sign often with these patients. So just like when we have our stroke patients, right, who get a lot of loss of that tone, you can get that same type of sulcus sign without any true neurologic injury. Okay. Management here is going to be physical therapy predominantly, and you'll see this with many of the joints. Your goal is to strengthen stabilizing musculature. The only thing that you can do for this patient, and this is what I described to them, the only thing we can do is to try to strengthen the muscles that stabilize the joint. So that means making the rotator cuff strong to hold the shoulder inside the joint, and that means making the scapular stabilizers strong so that they can support the shoulder, right? It also requires work with proprioception, and particularly about the shoulder. Working on that proprioceptive work with mirror therapy can be really, really helpful. Surgery can be used in a last-ditch effort. Generally, the goal is to reduce capsular volume, and an internal capsular shift or a capsular plication are generally your best options. So we can use that with our sports medicine surgeons if we need to. Okay. Moving on to the hand and wrist. This tends to be predominantly laxity at the carpometacarpals and mostly the first CMC. We don't really see much in the way of osteoarthritis formation, but these patients can be very impaired and have a lot of pain. It's not as commonly involved as other joints, but when it is, it'd be quite impairing. Bracing is a really, really important piece for this joint. So anything to provide some stability at the joint, thumb spica type splint, especially when patients aren't using it, can be really, really helpful to reduce pain and motion. When we talk about the hip, greater trochanteric pain or greater trochanteric bursitis and IT band dysfunction are very, very common. Paradoxically, in these patients who are hypermobile, the IT band is actually quite tight. I believe that this is a compensatory measure for poor proprioception and poor strength in the glutes. The IT band gets tight to try to compensate, but they will get external snapping of the hip, and they will get a lot of pain. Very interestingly, when we talk about the actual hip joint, they frequently have impingement, right? So about 93.8 have femoral acetabular impingement, and this can happen without pincer and cam lesions that are typical of femoral acetabular impingement. And this happens because they have such extreme range of motion that they're able to impinge the labrum simply with hip flexion. They are able to flex that hip forward enough to impinge and hurt their labrum. Again, the mainstay here is physical therapy. You're going to work on stabilizing the joint. You're going to work on keeping within a reasonable range of motion and avoiding those extremes. And surgical options include plication, again, labral repair and debridement as patients get more large injuries. But predominantly, we keep with physical therapy and strengthening. When we talk about the knee, there's rarely radiographic changes. However, this is a very common complaint. And so in patients who don't have any radiographic findings, this should be something that you consider. It is associated with ACL injury, so Beighton greater than 6, and especially with knee hyperextension, really, really high risk of injury to ACL. And this also, I should say, extends beyond just the hypermobile patients, but patients who are able to hyperextend their knees are at significantly increased risk of ACL injury. Importantly, even after you do an ACL repair, laxity will remain and risk remains. And so these patients are just at high risk for their knees. Again, mainstay here is physical therapy. The goal is to strengthen the knee to support it. Very interesting in the ankle and foot. Midfoot laxity is extremely common in these patients. You can diagnose this very quickly and easily. If you look at a patient when they are non-weight bearing and you look at their foot, it will have a perfectly normal arch. If you ask them to bear weight, they will immediately go flat-footed. You'll see pes planus. And it's because they're so lax in their foot that they cannot maintain an arch. They have dynamic instability of the arch itself. This causes a collapse in gait, which then impacts their gait mechanics. They get instability and they get strain in the foot. They get strain in the ankle and further up the kinetic chain, right? We don't exactly know what the effect of chronic instability is, but these patients experience a lot of pain because of it. So the mainstay again here is physical therapy to strengthen about the ankle and bracing, particularly medial support. We talk a lot about making orthotics for these patients while they are in rest, right? If you make an orthotic based on somebody's foot when they are bearing weight, it won't appropriately brace their foot. You have to do it just to support the medial foot. You could consider surgical options for stabilization, but generally speaking, bracing and PT and strengthening the ankle stabilizing musculature is sufficient. The spine is very interesting. There is some association with some cervical degenerative changes, but mostly it's actually instability and some cervical kyphosis. I think the most interesting part here is that people can get what's called a sagittal bowstring effect. And basically what happens is that there is enough range of motion in the cervical spine to create traction across the spinal cord. As they're able to reach such extremes in flexion and extension, it pulls. And so you can see symptoms of myelopathy and radiculopathy just from stretch. Right? If you go and get an MRI of their cervical spine, they will show nothing because there is no disc bulge or other neural compression that is identifiable on that MRI. It's just stretch. So it should stay on your mind. It's ligamentum flavum buckling that can also contribute. So as they go into significant extension, the ligamentum flavum posteriorly can push forward and cause injury. They also have a lot of mechanical neck pain, again from significant range of motion, but also because they have poor proprioception, they have a difficulty in holding their head up, and it requires more work, right? They're quite flexible, and they don't know where they are, so they're constantly making adjustments to their head, and they get neck pain, they get strain. There is some amount of atlantoaxial instability, however, not really that consequential. It's not like some of the other disorders, and you shouldn't worry about it from a true neurologic compromise standpoint. But you could see some syncopal, presyncope symptoms if you do have that atlantoaxial stability. Okay. With the lumbar spine, interestingly, it appears to be protective. So increasing flexibility in low back patients is actually protective for degenerative change. It's protective for radicular disc bulging, etc. So we think that this is actually probably better. And so if you have a hypermobility patient with low back symptoms, you should be considering other diagnoses, other problems, and considering imaging to actually evaluate, because it's unlikely to be directly related to their hypermobility. However, these patients have increased compression fractures. We still think that this is an issue with collagen in the vertebral bodies, but they have similar DEXA findings, they have similar bone density, so it's unclear exactly why. There aren't increased fractures in the rest of the body, but for some reason in the vertebral bodies, something structurally about them relies on collagen, and they have more compression fractures. For all of the spine, it's PT, it's strengthening. It really has to be working on making sure that you have a good posterior chain and a good core to support these areas. It's also working on trigger avoidance, and some patients do benefit from some bracing as needed, so they may require lumbar bracing for work, right? They may require postural braces to make sure that they stay in a safe location within their range of motion. And surgery is really only indicated for atlantoaxial instability or true myelopathy or radiculopathy. It's unclear if there's adjacent level disease. It's unclear what happens after you do surgery or fuse these patients, and there's certainly concern that if you do that, you may actually cause more problems. The sacroiliac joint I find to be very frequently involved. This is a joint, right, that deals with nutation and counternutation. We have typically only 2 to 4 millimeters of movement in the SI joint, and SI joint pain often comes from increase in movement. These patients have a lot of laxity about the pelvis in general and at the sacroiliac joint, and those things compound to cause increased movement and pain. They can have imbalance and asymmetry side to side within these, which again causes more motion, irritation, and pain. This is compounded by pregnancy. The hormonal changes of pregnancy already increase the laxity, particularly about the pelvis. That is amplified by this. These patients will have a lot of pain, and a sacroiliac joint belt can be a very, very good solution, both in pregnancy and broadly. Manipulation modalities can be helpful to try to get those SI joints back into an appropriate position. Strengthening about the pelvis is really the best thing, and working on motor control around the pelvis is also very helpful. They may have some adaptive postural changes which may need to be addressed to help with that extra motion, and it's just going to be a really strong home exercise program. I do prolotherapy for these. Prolotherapy is really just a dextrose solution that causes irritation. It's similar to platelet-rich plasma in that way. The goal is to create inflammation, irritation, and some scarring around the posterior ligaments of the sacroiliac joint, and that can be helpful to reduce motion, which can reduce pain flares. I actually inject this specifically into those posterior ligament structures. I do it under ultrasound guidance. Very simple and actually very, very effective. It's about a 15% dextrose solution, diluted from 50. Headaches are really, really complicated. Generally, they have some migrainous type, maybe mixed type. They have a lot of musculoskeletal features. We think there's probably some involvement from that dysautonomia and intracranial and peripheral vessel involvement. And that's compounded by cervical musculoskeletal problems, right? So things like paraspinal overuse, TMJ. There's some discussion of cerebrospinal fluid leak, although I can't find any convincing evidence that that's actually a problem. There is some association with Chiari malformations as well, but at the end of the day, these patients are just very susceptible to injury, and that just predisposes them to headaches. If you endeavor to treat this, you should expect single treatment failure. You should expect to do a lot of problem solving and troubleshooting and trying different things until you find something that works. And again, PT should be a big component because a large component of this is going to be musculoskeletal. So to wrap this up a bit, PT is essential, strengthening is essential, working on proprioception and mirror therapy is essential. These are big pieces, and they're going to be a pillar of treatment of any of these patients. We think about using Alexander technique, among others, for working on our proprioception. We want low resistance, and we want a graduated increase. Okay? Often with these patients, they're young, and we try to push them too hard because they're young. That's probably the number one thing that I see when I treat these patients, is that they tell me that they've been to therapy before. They tell me that they've tried exercise before, but it made it worse. Right? And it often makes it worse because they're 25, and we try to put them in situations where they are working hard and getting hurt. And so we have to really, really slowly increase that. You can use the hypermobility, and we teach them to use that hypermobility in ways that are advantageous to them. But if they're doing something that's either going to put them at risk or is hurting them, we have to avoid it, right? Within sport in particular, and we'll talk about it in a second, but this hypermobility can be quite helpful. I really want to focus a lot on the proprioceptive and the balance work. It's really, really key. These patients are really bad at it. In addition, we should really be trying to avoid open chain exercise. So open chain exercises create a lot of instability in joints, inherently. That's why we usually like them for patients. We want that instability because it's good for building good strength and functional strength. However, in these patients with impaired proprioception, open chain exercises are going to cause injury because they're unstable inherently. And so when you try to have somebody lift a free weight, they'll just move their joint around and hurt. So we should be trying to focus as much as possible on closed chain exercises to help them. And pelvic floor therapy can be helpful for a lot of these chronic pelvic floor instability and SI joint pain. Exercise does appear to help. There's not really any good evidence that I can give you. Generally, I just recommend that people do aerobic exercise, whatever works for them within their ability. Swimming, things in the pool can be helpful, right? Those are obviously very low impact and can be useful, although I have some patients who do very poorly with it. It appears to help. I would always recommend it. You use bracing as needed for things that are beneficial. You don't want to make somebody weak with bracing, but if they need bracing for comfort for their back, for their thumbs, whatever it may be, it can be helpful. And it may be helpful as a proprioceptive tool to give them some feedback from as they're making movements. Right? With medication, we think of layers, things like NSAIDs, topicals, muscle relaxers, and neuropathic pain medications can be helpful. Oral magnesium can be helpful if patients experience a lot of spasms. We try not to use opioids. Patients with these disorders do very poorly on opioids, and they are extremely hard to get off of opioids. They rely on them, they do form addiction, and they do really struggle. We use injections as they are appropriate to treat those big acute episodes. So think of corticosteroids, hyaluronic acid, and for things like the sacroiliac joint, prolotherapy can be quite helpful. There is some talk of sclerotic agents. There are some studies, but there is certainly no good evidence to use those at this time. If a patient does choose to pursue surgery, they should expect mixed results. They are using surgery to treat very lax tissues. And those tissues that are already quite mobile will remain quite mobile even after surgery. And so it may not necessarily solve your problem. There is a lot of autonomic dysfunction for those. Just the general treatment principles are to increase fluid intake, increase salt intake, and also time intake. Encourage patients to drink water before they get out of bed in the morning to help improve that tolerance to being upright. Take time before getting out of bed. The same things that we talk about with many of our orthostatic patients. Lower extremity strengthening can also be helpful for some of this autonomic dysreflexia, autonomic dysfunction. And fludrocortisone and midodrine can be used in really extreme cases. Just briefly talking about sports, there is no true contraindication for sports. And again, many of these patients with hypermobility do quite well with sports and are quite successful. It is okay to use the hypermobility so long as it's not causing injury. And in some cases can be protective, like the low back. However, you do have to be careful with joints, and autonomic dysfunction might be limiting for some of these patients. They should operate within their ability and strength. The stronger they are, the better they are at what they're doing, the better they're going to be able to operate within that hypermobility. And they may require some PT and some special training to use that and to really access that well, especially as they get into higher levels of competition. And again, bracing as needed in these patients in ways that's advantageous for them. So this is a psychiatric, neurologic, autonomic, and musculoskeletal disorder. As such, it requires care of all of those domains, right? It does have a high impact on health-related quality of life, and a high likelihood of seeking care and utilizing care. There are some good evidence for intensive treatment, so some places are using inpatient rehabilitation. However, there's no clear evidence for exactly how to pursue that. I do warn patients that pain rarely improves greatly, however, function does. You can do things to make yourself much more functional, but you will probably always have some pain. You can do things to help with pain and function, however, if you stop doing them, you will backslide quickly. So I tell all of my patients that it does require work. It requires effort, and it requires a lot of maintenance to really, really succeed in having this. I also tell them that that's very unfair, right? It's a really challenging thing to have. But if you can teach them to do this, they can often manage themselves. Recognition is really key. This is really easy to miss. Because there's no good evidence from a radiographic standpoint or otherwise to tip you off, you have to always be thinking about this as a possibility for your patients that you can't quite explain. Having a multidisciplinary team is essential, especially for the long-term management, as they do really require a lot of kind of constant care. They will come back, something else will hurt, you'll make sure it's not serious, and then you treat them for whatever joint is hurting them. And that is what I have today. Do you guys have any questions?
Do you find that the symptoms are worse when a patient comes in who's pregnant or post-pregnancy and they're breastfeeding, who is diagnosed with this? Is it compounding the laxity they already have with even further laxity, so those symptoms might be more aggressive at those times?
Absolutely, okay. Yeah. Also interesting, pregnancy actually permanently increases patients' flexibility. So there's something about those hormonal changes that will, in a long-term sense, even well beyond breastfeeding, well beyond that pregnancy, women who have had a pregnancy, women who have had a child, will always be more flexible than women who have not. So that is a general population principle, but that is only compounded in this population.
And then in your experiences, you said it's more common in females, and you do the testing and you diagnose them, but do you find that in your experience, so it's been a certain age group that comes to your steps, to your door, that you find most prevalent in, like, I don't know, women of a certain age or of a certain vocation or of a certain sports population or something of that nature?
I think in general it's probably patients in their mid-20s, early 30s. I think that there's something about that age group that has previously done functionally quite well and has likely been able to use that hypermobility or compensate for that hypermobility for some time, and then reaches a point at which they are no longer able to compensate. I think many of us, when we reach that age, we find that we're not as capable as we were, and I think that hits this population quite hard as they are no longer able to do it, and that's when the pain starts to catch up. That's when they start to really, really struggle.
Just as a comment, I think maybe it's when people go to enter the workforce and they're graduating from college and they're not as active as in their teenage years, right? So they're not using muscles the way they would have on a regular basis, and they're sitting more often, is my thought. Yeah,
that's really, I've never considered that, but that's quite likely.
So a follow-up question from that. So I used to have the patient who come for the surgery of the patellar tendon because she has like patellar dislocation.
Yeah.
So in pediatric, do you think which age that you can really test for hypermobility syndrome?
So you can test for it. Again, the criteria is just 6 or greater on Beighton. In those patients who experience it quite early, it does seem to be more severe in my experience. And so those patients often have some autonomic component as well, so they'll have POTS or something else in conjunction. Patellar instability can be difficult because there are some patients who just have a variance in the actual patella shape. So if it's quite flat, it's really easy to dislocate. And so some patients, it's not necessarily a hypermobility issue, but it's really just an anatomic variance issue. But if that patient were to have a bunch of other joints that hurt and a bunch of flexibility and instability, then yeah, absolutely. You can diagnose this in pediatric patients. Again, the pediatric patients tend to be more resilient. And so I think that they probably have it to some degree, but they haven't accumulated all of the injury and they're still strong enough to compensate well. But if you ask them, they'll tell you that they're clumsy. They fall.
Okay.
Yeah.
Another question, in fibromyalgia, from your experience, how many % that you see that like you found hypermobility from the patient who had fibromyalgia?
Oh. I don't know about percentage. I do find a high number, maybe I'll say this, I find a high number of patients who have been previously diagnosed with fibromyalgia who really just had hypermobility, who are sort of inappropriately diagnosed, because it makes sense to diagnose it that way. I mean, if you have somebody who has no radiographic findings and they hurt all over, it sounds like fibromyalgia. But they won't have tender points, right? They won't have some of those other features of fibromyalgia, and they'll have these complaints of subluxation and joint instability. So I don't know what percentage of fibromyalgia patients are actually hypermobility, but I can tell you that a high number that come in diagnosed with it, they actually have this. Yeah.
Thank you.
Yeah.
Okay. From your perspective, what play the dominant role in the chronic pain in the HSD? Structural instability, central sensitization, or impaired proprioception, and how should this influence rehabilitation design?
Yeah. It's really tough because I think it's really the kind of collection together. I do think it's the chronic instability that causes the most pain, but that chronic instability is there because there's poor proprioception, right? It's there because there's just this sort of inherent instability to the joint. I think the things that can be most helpful in creating a rehabilitation regimen for them, I mean, one is recognition and communication of that to the people that are involved. Right? And again, like we talked about, having a mostly closed chain treatment plan is going to work much better for them. I also think patient education is really important for this. A lot of this has to be patient ownership of the disease. They have to do these exercises at home consistently themselves to really succeed. And so a lot of it is really talking to the patient about that and giving them the autonomy to do their own treatment. But I think that you're correct that the proprioception is another important piece in here. That is really, really important. And including that in that treatment regimen with mirror therapy or otherwise can be really, really, really useful. So I think it's just working on a home exercise program. It is communicating with everybody on the team exactly what the expectations are and what therapeutic treatments are going to be most helpful, and working on proprioception in therapies. Yeah. Yeah, of course.
Just
From the
one.
record, any question for Dr. Kathy? Seems no more.
Just one more.
Thank you very much.
Just because I think it might be interesting is, do you find that a lot of the patients have a lower skeletal muscle mass compared to fat mass? Because if it is a weakness or instability issue, do they have less muscle mass and they're typically not tone or in shape or overweight? Is that usually a correlation that you find?
So interestingly, I don't see very many who are overweight, but I do think that they have less muscle mass. I think I've seen, unrelated to hypermobility, but a lot of patients who have pain have atrophy and poor muscle mass and tone from poor activation of muscle. In particular, I've seen a lot of total knee replacement patients who have atrophy, and we're worried that there's a neurologic component, and there's not. They have atrophy from pain and disuse. I think these patients similarly have a atrophy due to pain and disuse. And so they don't, interestingly, not usually obese, but yeah, definitely low tone. It compounds. It's challenging because of how much it compounds.